I want to thank MedX and thank Corey for inviting me to talk about this, I think, very important topic, and quite nicely fit right after talking about how trials need tissue, and perhaps liquid can circumvent some of this. So, using liquid biopsies to make better treatment decisions, answering the 5 critical questions. So I've been given a question as my talk: will liquid biopsies replace tissue biopsies? And I've answered that with 5 additional questions. I'm going to walk you through that. Okay. Here are my disclosures. So we know lung cancer is heterogeneous. We've seen this slide over and over again. Molecular enrichment is paramount. We can now take patients who have lung adenocarcinoma, we can parse them out into molecular subsets, and then we can wed those molecular subsets to targeted therapy. And for all of us in the room who've given genotype-directed therapy, we know the benefits of this. We know the importance of response rates and progression-free survival. We know, importantly, perhaps underrepresented in the literature, is improvements in quality of life, which may become a more important metric as MACRA and the value-based system rolls out for delivery of healthcare. But tissue's challenging. This is my tissue biopsy timeline, and I will tell you, you'll see multiple arrows throughout this talk. They're peppered throughout the talk. And we know that tissue biopsies can take time. The turnaround time is around 2 to 6 weeks. Of course, we start with the biopsy. It can be invasive. We have to decide optimal tissue procurement, and there are risks to the patient. All of us who've referred our patients to tissue biopsies understand this. And then, of course, tissue stewardship, a term I would have loved to trademark. It's been used so many times now in terms of processing, sample availability. And then what are you going to use as the optimal interrogation? Is it going to be a Nextgen sequencing? Is it going to be an ion torrent system? All of these things play a role in deciding how tissue is going to be processed. And then finally, reporting. For those of us in fragmented healthcare systems or even in siloed health systems, how are we going to get that information? We're sending off this tissue. It's being done. Is the report being faxed to us? Is it being faxed to the pathologist? Then the pathologist passes along to us. We need this information quickly. I can tell you at Sinai we've had some challenges with this. So enter cell-free DNA or circulating tumor DNA. What probably once thought to be science fiction, we can now make a lung cancer diagnosis and also genotype the patient off a simple blood test. And the capture of cell-free DNA is now, we're able to do this. We know that circulating tumor DNA is shed in the blood. It's shed as a product of apoptosis and necrosis, 2 very relevant processes in cancer. And fortunately, we now have diagnostic platforms that are sensitive enough to pick this up in the blood. And the question really is, now that we have this technology, does it or can it circumvent the need for tissue biopsies? And this is where we get to the questions. But there are lots of different tests out there, by the way. I'm sure if you're a practice, a provider, a clinician, you may be familiar. These are either quantitative PCR, digital PCR like beaming and droplet digital PCR, as well as NGS platforms. And I'm not here to favor one or the other. I'm here to tell you that they're commercially available and have been validated in the lab. So let's talk about how we can use these platforms along multiple lines of therapy. So this is yet another arrow. Driver mutation positive patient. We have a potential to use it as diagnosis and to perform molecular interrogation. We, of course, have the potential to use it upon progression to identify resistant disease. I will show you data that perhaps looking at this as a dynamic marker, not as a static one, looking at changes over time in terms of real-time monitoring of treatment response, as well as identifying resistant mutations prior to disease progression. I don't think we are ready for prime time in this measurement, but certainly the data is quite compelling. And then obviously patients who get that next-gen therapy after the resistant mutation is identified, perhaps resistance to that next-gen therapy. And this, of course, has played out most prominently in the EGFR positive patient. And we'll spend some time on EGFR interrogation off the blood. And patients, obviously, who are EGFR positive are getting either a first or generation TKI. There's a potential to use this at the time of diagnosis if tissue samples are unavailable, or you've made a diagnosis of lung cancer, but you don't yet have enough tissue for molecular interrogation. We can, of course, use it to identify T790M. I'll show you data to suggest that we should perhaps start with plasma. And if plasma is negative, then consider the tissue biopsy. And then after the delivery of a third generation TKI, perhaps identifying tertiary mutations. So question one, 5 questions. Question 1, can liquid be used as a reliable molecular proxy for treatment-naive EGFR-positive patients? And there's really 2 ways to answer this question. One is to look at concordance between plasma and tissue from the same patient to see how concordant plasma is to tissue from the same patient. And this is data, this is from a review article that we just published, and the oncologist reviewing all of the studies that have compared plasma versus tissue. And the bottom line is for EGFR mutations, the sensitivity ranges anywhere from 50 to 70%, but the specificity is quite high at 90%. Remember, specificity rules in. So if you have a plasma test that's positive, you can potentially trust it, and that it is serving as a reliable molecular proxy for treatment-naive patients. Perhaps the best data was prospective data, one of the only prospective trials looking at concordance between EGFR mutations in the tissue and the plasma was performed by Adrian Sacher and Jeff Oxnard from Harvard. This is their homegrown assay. And the sensitivity of EGFR mutations in this prospective study was 75%. The specificity was 100% positive predictive value. If you were positive in the blood, you were positive in the tissue, period. If your blood test was positive, that essentially ruled you in. The T790M story is a little different. The sensitivity is around 70%, but the specificity is a little bit lower, and we'll talk about that. Interestingly, but quite perhaps clinically intuitive, the higher number of sites you have in terms of metastatic disease, the more likely you were to identify cell-free DNA in the blood. The more tumor burden you had in your body, the more likely you are to identify the cell-free DNA in the blood. And perhaps, like as I was saying, you can look at concordance rates between plasma and tissue, but can you also look at response rates between patients who are plasma EGFR positive who get a TKI compared to response rates to the patients who are tissue positive who get a TKI. And this is a confirmatory phase 4 study looking prospectively at the role of gefitinib in patients that were EGFR positive. And not surprisingly, patients who were tissue EGFR positive had a response rate to a TKI of around 70%, which wasn't that far off from patients that were plasma positive. So again, plasma may be used as a surrogate for tissue. So question 2, is this a reliable molecular proxy for resistant disease? Now, we're still sticking on the EGFR positive patient. And this was data presented a year and a half ago by Alicia Sequist, evaluating 247 patients who were T790M positive who received ruxolitinib. We mourn its loss, the drug. But the bottom line is the concordance rates between tissue and plasma for T790M was as high as 80%. But this is assuming that tissue is the gold standard. When you draw out those sensitivity and specificity tables, you're assuming that tissue is the gold standard in these cases. And I'm not sure that's the correct way to look at things. Nevertheless, the concordance rate in the resistance setting was 80% for T790M. Fast forward to ASCO this year, data presented by Heather Wakely, looking at 181 patient samples who had matched pretreatment T790M for plasma, tissue, and urine. All these patients got ruxolitinib, and the 57% were positive by all 3 samples. You can take a look at this and say there's very few patients who were only positive for T790M by one of the measurements. Most of these patients did have overlap. But perhaps more important, the response rates were identical, whether you were tissue, plasma, or urine T790M to ruxolitinib, again suggesting that plasma can serve as an accurate molecular proxy when making treatment decisions. And I'll end up talking about some limitations. Nevertheless, I think this data is just as important as the concordance rate between plasma and tissue. And then most recently, data presented in the JCO by Jeff Oxnard looking at osimertinib, a approved T790M-directed therapy, looking at 216 patients with both central tumor and plasma genotyping available, and consistent with the data I've shown you before. Patients that were tissue T790M had response rates that were identical to patients that had plasma T790M identified, suggesting again that plasma may be able to serve as a molecular proxy when interrogating T790M. And this is the paradigm that we currently are looking at, and as all of oncology, the paradigm is shifting rapidly. The current paradigm, I think, has been that patients who are on an EGFR TKI, who do have developed progression, biopsies should be done. If the biopsy is positive for T790M, deliver the osimertinib. I think that paradigm, it can be reasonably changed based on this data. Patients who are EGFR positive, who develop resistance, I think it's reasonable to start with plasma. If plasma is positive, deliver the drug. You can be rest assured the response rates are identical versus plasma versus tissue. If it's negative, however, you can't stop there. You have to do the biopsy. Remember, the sensitivity of T790M is a little bit on the lower end. You gotta go for the biopsy. So I think plasma T790M patients, rest assured, their response rates are going to be identical if when compared to tissue T790M. What about additional mutations after third-generation TKIs? The story doesn't end there, guys. You identify the T790M, you deliver the third-generation TKI, and now we've identified tertiary mutations after the third-generation TKI. There's a new mutation identified called EGFR C797S, and we're going to start playing a game of whack-a-mole. We're going to basically hammer one mutation down, another mutation comes up, and so this game of whack-a-mole may be aided and helped out by plasma, and we've of course had two groups that have identified the EGFR C797S, one from Memorial and the other from Dana-Farber. One of these did identify it in the blood, the other was in the tissue, but I think we're starting to learn more about this tertiary mutation that importantly, incredibly, may be responsive to first-generation TKIs. What about real-time response and early relapse? And we're not here yet, but I think this is where we're heading, looking at this as a pharmacodynamic marker, as a dynamic event, not a static one. And there's been some nice data published in the JTO just last year. It was presented at World Lung, then subsequently published. Very simple study. Patients that were EGFR positive received a TKI, and then they followed blood samples longitudinally and looked at the EGFR load, and they identified two groups of patients, a fast responder and a slow responder group. The fast responders had a certain % drop in the EGFR copy number in the EGFR mutational load in the blood over 14 weeks versus the slow responders that didn't. And interestingly, and perhaps clinically intuitive, patients who were fast responders, their mean percentage of tumor shrinkage at 6 weeks was 60% compared to the slow responders, their mean percentage of tumor shrinkage was only 18%. And I guess the question is, I guess the fast responders would not help us make treatment decision changes, but do the slow responders, if we knew that a patient wasn't going to have that drop, that correlated to the lack of response at 6 weeks, could that inform treatment decisions earlier? And Jeff's data and Satra's data also looked at a small group of patients. This is the prospective study that I mentioned earlier, comparing plasma and tissue, looking at a small group of patients and showing again that it looked like drops in number over time did correlate to outcomes as measured by whether patients stayed on treatment or discontinued treatment. Question 4, what about NGS? I've spent a lot of time on EGFR mutations, but what about next-gen sequencing beyond just the EGFR patient? And this is where I think we're really heading. This is data that was presented by Phil Mack at ASCO. It hasn't been published yet, and of course the Penn Group has a prospective study that looked at this platform as well. Digital sequencing of critical exons in 70 genes. This was looking at more than 15,000 patients performing genetic interrogation off the blood on a next-gen panel. Most of these patients were stage 3 and 4. Most of these patients had received 1 or 2 lines of therapy. What's important, and for the clinicians in the room, you need to have some fluency in the language. You look when you order these tests that are next gen in the blood, they come out and report as a mutation allele frequency. And I don't want to get too much into the weeds of what a mutation allele frequency is, but it's basically the amount of mutant DNA over wild type DNA in the blood. And most of these mutations were identified in these 15,000 patients at a mutation allele frequency of 0.4%. That will come in handy when we go over a couple cases I want to show you. And there was a high detection rate across most cancers. In lung cancer, more than 85% of patients had a mutation identified in the blood. And importantly, when you looked at roughly 300 patients that had both plasma and tissue, comparing the two, again, a metric, a way we can measure the accuracy of these plasma platforms, the positive predictive value was quite high at 94%. And even for those patients who had a mutation allele frequency of less than 0.5. So can we trust this Nextgen when we order it in the blood? Does it concord with tissue? Well, it looks like based on this data, the answer is yes. And then perhaps just as importantly, when they took 360 patients with adenocarcinoma and did tissue genotyping on them, they were, of course, able to identify relevant driver mutations, a total of 120. But when you added plasma to that, when you took those 362 patients, they also did plasma Nextgen sequencing. The plasma was able to pick up on an additional 51 mutations that were either missed or not tested for on the tissue. And it increased the biomarker yield by 42%. Now, I'm not arguing that every patient who has a tissue biopsy should also get Nextgen sequencing up front. What I'm saying, and perhaps we'll find out later if this is reliable or not in prospective studies, patients who have a tissue biopsy in which you've made a diagnosis of lung cancer, but you don't have enough tissue for molecular interrogation, I think it is reasonable to use plasma in these cases rather than rebiopsy them. And I think we've got prospective data from Penn to show a couple of things. One was that the rate of tissue failure, I don't want to say tissue failure, but the rate of they took 100 patients and 50% of those, Corey, correct me if I'm wrong, the tissue was not enough to perform the molecular interrogation. And they had paired plasma as well, but I think it's reasonable to consider plasma in these cases. We need more prospective studies looking at the predictive value of plasma to targeted therapies. And these are just two studies, two of my own cases, and I don't want to spend too much time because I'm running out of time, but these are two cases. One is a patient that is EGFR positive who was identified with an L858R in the tissue. He was started on erlotinib. The patient eventually developed disease progression, and when we were ready to make a switch, we ordered a plasma test to interrogate for T790M. Just a teaching point here. First of all, the plasma picked up a L833V mutation that was missed in the tissue, a very rare EGFR variant. That's number one. That was there all along, just missed in the tissue. Secondly, if you identify the T790M in the blood, it has to come with the sensitizing EGFR mutation. If you have a T790M and you don't see, in addition, the the sensitizing mutation, it's probably a false positive. And finally, the T790M mutant allele frequency, sorry to bring that term up again, is always going to probably be at a lower rate than the sensitizing mutation. Not always, but usually. So many clinicians may look at this and say, oh, this tumor is still driven by the sensitizing mutation. Not true. Most likely driven by the T790M. It's just occurring at a lower mutant allele frequency. Second case, briefly, patient who is 38 years old, came in, had a tissue biopsy. It was negative for every for our genetic interrogation. We ended up doing a second test because I am convinced you can find driver mutations in those under the age of 40. There's actually a study called Young Lung Study that demonstrates that the prevalence of ALK in those patients under the age of 40 can be as high as 40%. He had some pathological clues that he may have an ALK mutation. We ended up plasma genotyping him, and indeed, even though his tissue was negative by FISH, we did pick this up at a mutant allele frequency of 0.9. He's on crizotinib and responding quite well. So again, these are, I think we need more data, but certainly compelling, and we're just in its infancy of trying to understand this. Finally, is there a role in early diagnosis and monitoring of minimal residual disease? Circulating tumor DNA, cell-free DNA is great for stage 4 patients, but the intent is palliative in these patients. Can we use these platforms earlier to help cure patients? And there's been some nice data from the colorectal cancer literature showing that patients with resected colon cancer, in which you then assess longitudinally for circulating tumor DNA, that may inform of recurrences. And it's a small study looking at patients who had undetectable DNA versus those that had detectable DNA, and there was an association with recurrence-free survival. In fact, if you had undetectable DNA, there was zero chance you were going to recur versus those in which you had detectable DNA. So I think there's a lot we can learn from this. And then, finally, this is work that's still being done looking at a an mRNA in the blood. And this study, it was just trying to explore whether you could distinguish patients with lung cancer from patients without lung cancer. And this is where we need to head. We've got CAT scans that are available for our patients, low-dose CT scans that may pick up on nodules. Can we add blood that may help discern patients with and without lung cancer? And incredibly, this blood test from mRNA was accurately able to distinguish patients with lung cancer versus controls, and more importantly, be able to distinguish stage 1 patients versus controls. We talk about cell-free DNA being shed in the blood for patients who have metastatic disease. This was something that could be identified in stage 1 patients that may inform whether a patient has lung cancer or not. And they followed these patients longitudinally, and again, this is a theme I think we have to start to weave with blood tests, looking at these longitudinally to see if they can correlate with outcomes. So summary, genetic interrogation is paramount in optimizing frontline decisions and helping to select genotype-driven therapies. I think cell-free DNA has tremendous promise. We need prospective studies. I think in the resistant setting for T790M, we can reliably use it and help deliver therapy. If T790M is negative, consider a tissue biopsy. It can perhaps be used in the for treatment-naive patients in which you've done tissue interrogation, it has been insufficient, you've made a diagnosis. I think it's worth a consideration, although currently not standard. The standard would be to re-biopsy these folks, but I think in our experience, we've used plasma in this setting. Real-time monitoring is we need more data on this, looking at this as a dynamic marker rather than a static. And hopefully we will have future studies looking at these platforms for potential cure, to help with cure, to identify resistant disease earlier than a CAT scan is. And with that, with my cough, I'm 5 minutes over, and I would like to say thank you. Sorry.